Hello, I'm Dr. Diane Duncan, and I'd like to welcome you today to the live webinar on exosomes sponsored by Exico Bio. Today, we'll have some very interesting speakers discussing the evolution of regenerative medicine, current research that's going on. I'll be presenting clinical aspects and use of exosomes, and Dr. De Felipe will present his research and clinical results on hair. This morning, we're going to start with my dear friend and colleague, Dr. Cohen, who will take us on a journey through the beginning, middle, and current state of regenerative medicine and exosomes. Steve?
Thank you, Diane, and it's nice to be here. What I wanted to share with you is my story and my involvement in regenerative medicine, because this has not always been an easy one, and our colleagues have been a little bit resistant to some of the newer ideas that are coming out of this. And part of that is because of the shenanigans of promoting stem cell facelifts, and part of it is just a lack of knowledge. Well, presently, a course like today will bring them up to date. So this is just a brief personal story. I'm in La Jolla, California. My disclosures won't affect my talk. Joseph Murray, a plastic surgeon who was a Nobel laureate in medicine for doing the first kidney transplant, really discussed at least the evolution of surgical stages. And at this point, really, the thought is regenerative medicine is the stage we are beginning to enter. Now, what about regenerative medicine? It's really trying to sort out how do we use the body's own functional restoration processes and natural healing by manipulating our cells, our matrix, and the various factors that are signaling tissue to be repaired. So stem cells have two main attributes. One is potency. You know, we can make a human being or an animal, and the other is self-replication. These cells can, you know, make themselves again. So fat can turn into fat, or with certain stimuli, fat can turn into other tissues. Now, embryonic stem cells that have huge promise are quite a distance away still from any kind of therapeutic use for many reasons. But adult-derived stem cells and mesenchymal stem cells have become very, very popular these days. Now, when this article came out in 2001, I happened to be practicing in San Diego, and interestingly, Mark Hedrick and the UCLA people approached a company I was involved with, and that company was called Macropore. And Macropore decided to buy a little company that had been started by Hedrick and Adam Katz and Bill Futrell. And this was called StemSource. So we bought this company. And the reason that we thought this was interesting was for a couple reasons. One, you know, if you think of like, where did we get digoxin from a plant? Well, it makes sense to me that we would find many complex mechanisms and potentially treatments within our own systems that could be capitalized on. So this is to me what was very appealing from a therapeutic point of view. Now, of course, this has been, you know, almost 20 years in development and things have changed, but initially it was felt that if we could take these cells that are clinging to the small vessels and we could harvest them enzymatically, we would be able to use these therapeutically. And these stromal cells and vascular cells, of which stem cells was a small percentage, seemed very, very interesting at the time. And we were able to get these out of an enzymatic process. We were able to actually build a machine. And of course, what comes with these stem cells are numerous growth factors. And now we're beginning to think perhaps the mechanism of action may be really even more particular, and that is through exosomes and its communication, which Diane and Tunch are going to discuss. But one of the things to note about regenerative medicine in general is that these materials and growth factors, they have a cascading effect when they're put in the body, and they express themselves in a way that lasts sometimes up to months after implantation. So you can take a device, use an enzyme and create stromal vascular fraction that can be used in many different ways. And only because of time, I want to skip over things. So some of our first cases, this is Ramon Huey's first case. This is, to my knowledge, the first time these adipocyte-derived stem and regenerative cells were used for therapy in a hand case. Here are cases. This is the 3rd through the 11th case done. This is actually the 3rd case where we used these cells in addition to fat for regenerative purposes, for aesthetics. And you can see this woman 6 years later and the effect on the perioral wrinkles and the smile lines. Another woman, the same kind of thing. You began to see not just a improvement in a fold, but you began to see a widespread improvement in the tissue. It's almost like you took a plant that was starting to wilt and you watered it and it woke up. You were seeing these regenerative effects, which led us to begin applying these kinds of treatments with mesotherapeutic techniques really in the early 2000s, 2003, 2004, in cases for burn scars where we began to see actual scar reversal without necessarily fully understanding the mechanism of this. We were able to start to see dermal thickening and reversal of wrinkles. Again, thinking that somehow these are stem cell effects, but really not knowing what particular musician in the orchestra was responsible. Look at the pigment changes under the eyes. Again, these became anecdotal and gradually were corroborated by researchers like Ragati and his group out of Italy, Charles Dessau out of Brazil. And you could see true reversal of age-related changes in elastin and collagen fibers and a reduction in inflammation in skin. Well, that was cool, but look at what else we were doing. We were taking these cells and we were injecting them in patients who had acute heart attacks because, again, if we could stabilize the injury, if we could salvage a certain percentage of cells that were at risk on the periphery, we may be able to reduce the number of patients that progress to heart failure, and we may be able to reduce the frequency of arrhythmias. And so we were beginning to take fat, harvest these cells enzymatically, inject them directly into a coronary artery within 24 hours after a heart attack. And you were seeing that patients actually responded and did well, and that you were seeing a lower frequency of arrhythmias in the treated group. So the potential for these kinds of regenerative therapies became very, very substantial. This was also applied not only in a heart attack study, but in refractory heart failure, where we began to see improvement in functional recovery of the heart based on MVO2 18 months after treatment. And these were patients that were on a transplant list that either didn't progress or were kept out of the hospital. In the US, trials began, multiple sites. The problem with all of these trials, in my opinion, is in spite of these enormous anecdotal cases that we have and we've accumulated, the trials are difficult because we're not controlling for our DNA. In other words, some people have dead cells that you're using. So if the cells are senescent, why would they work? Other people may have other factors that are involved. This is a complex system and we don't fully understand it. And in fact, one of the exciting aspects of the exosome is perhaps this is maybe one of the main ingredients that actually are functionally doing this. So maybe we don't even need things like nanofat or SVF. Maybe we need only exosomes. We don't know this, but we know that we can heal chronic wounds with these materials. We know that we could restore breast tissue in various trials. Unfortunately, statistical significance was difficult to reach. But again, think about this. We're using these patients' DNA. Some patients are younger, they have healthier cells, they perform differently. So there's an enormous amount of variability. It doesn't mean that there's a problem with the actual treatment. Can you advance this slide? It's not working for me. Now, the problem with enzymatic dissociation is it's more than minimal manipulation. So it's not approved in the US. The studies have not shown statistical significance. And the current applications that we're working on are mainly anecdotal, but they're very, very extensive. And these are things that exosomes or these techniques in regenerative medicine have all been shown to potentially have um, effective treatments for. One of the things I've been most interested in is regenerative approaches for aging. So here's the real circumstance. We can't change chronologic age, but we certainly can begin to affect biologic age. And biologic age can be affected by a variety of things. And we can measure the effects on cells with new types of techniques that measure genome-wide methylation profiles, telomeric length, et cetera. And we can begin to determine whether these kinds of treatments, such as modification of our diet, reduction of stress, exercise, new pharmaceuticals that are being developed for anti-aging, and regenerative approaches actually do work. So the question I've been asking in facial aging is, can we delay or reverse this? And what we're looking at is a more dynamic approach, not simply the patient walks in, you look at them and we go, oh, they look great and we just need to do a facelift. Now we're looking at, can we modify their decay curves? Can we change the way they age? Can we prolong the life of their tissues in their face? And I think we can by beginning to understand more accurately, both on a anatomic level and a physiologic level, how the patients age. And if we can begin to understand what's happening anatomically and cellularly, we can begin to take new products like exosomes and apply them in ways that actually prevent our deterioration as well as reverse certain findings that occur with the aging process. So I'm going to just skip through because really I don't want to talk about fat grafting. I want to talk more about regeneration. And the problem we've had with, in general, plastic surgery is that we're treating patients purely aesthetically. And what I'd like to do is just say, we can look at the face, we can determine where the aging occurs, we can replace the exact kinds of volumes with comparable volumes that we've lost over a period of time. And if we start to recognize differences in the tissues, we can augment the tissue by creatively adjusting our fat graft to both a structural graft for deep replacement, a superficial graft for superficial fat compartment replacement, and things like nanofat or potentially things like exosomes for regeneration. And when we start to apply these things, what we find is that, one, like any system, we need to begin to process what is most effective. So when we take nanofat using a device like this, and we realize that we're trapping the fibrous tissue that actually is the niche that these cells live in, we begin to think about new techniques. And can we create a device such as this one that allows us to harvest fat and to convert it by a cutting technique and an emulsification technique into a cell optimized fat graft or nanofat. And that's what we've been working on more recently. And I know Tunç is going to extend this with other comments. So when we look at that, sorry, my slides are not easy to, there we go. When we compare what we're getting out of this, we begin to see we get more cells and we have a more effective device because we're having a different type of cell output. And that seems to be critical. Now, here's the interesting thing. When we look at these patients that have had facelifts with fat graft, and we actually see that the facial volume improves over time. So we're seeing a trophic effect without any weight gain in these patients. So we started to apply this to younger patients. And this is, again, where I think things like exosomes will play an enormous role, because as we manage our decline, we need to be managing that on a serial basis. And simpler types of treatments like exosomes that don't require necessarily surgical applications become very helpful. But you take a woman like this who's coming in for fillers at age 30 and wants fillers in multiple spots. If we replace her fat with the deep fat or structural fat, the superficial compartment fat, and the nanofat for stimulation, you can start to see the effects a year later in terms of not only the appearance change, but regeneration of tissue, improvement in the skin. And with biopsies, we would see improvement in elastin and collagen fibers. So the whole goal of these treatments are to take patients at these younger stages and begin to slow things down. Now, we looked at this also, and we looked at 30 patients that were treated just with isolated fat grafting, anatomic and regenerative approaches. And if you looked at this, it was very interesting. The curves for the older patients over 55 gradually degenerated to 30% improvements at almost 2 years, whereas the patients under 55 showed these trophic effects or rebound effects. We started to affect the aging curve. So without further ado, I think this is really where I'd like to leave it, because the mechanism really of how these stem cells and how the regenerative cells work have largely been unknown. We know immune modulation, we know tissue repair, we know increased blood supply, but we don't exactly know what is responsible. And I'm beginning to think, as we learn more, that the responsible entity may indeed be the exosome. And I'm going to turn this over to Diane and Tunç, because they're going to bring us into the age of exosomes. Thank you very much. It's just a brief outline.
Thanks very much, Steve. That was wonderful. A really nice journey through the beginnings and evolution of stem cells and nanofat. I did have a quick question for you in that I wanted to know, I know you really are just really getting into using exosomes. When would you choose to use exosomes, or when would you choose to use fat and nanofat?
Well, presently, Diane, I would say probably I choose to use them both in conjunction, because I don't know what is going to be more effective. I think we'll be able to sort that out in some relatively simple studies, but I look at perhaps using the exosome either together with the nanofat or eliminating nanofat and using exosome in its place, because if that turns out to be the true messenger and the real mechanism of action, why bother with the other stuff? I don't even know that you need it. On the other hand, until we prove that these cell aggregates are not necessary and that they're not other ingredients that are important or somehow augment the effect we might see from the exosome messenger, I probably continue to use both. I've now used a product, actually ExcoBio's product, a couple of times, or I should say Benev's product, and I've been very impressed with how quickly wounds heal. And in fact, I was actually kind of surprised. So I think that the role of this is going to be an enormous role throughout medicine, quite frankly. I just don't know the relative pros and cons yet until we actually make comparisons.
Thank you.